Welcome to Module 4, Perinatal Data Issues. In the previous modules, we have looked at health data, what it is and how to define and manage it. We have looked at how to determine if it is fit for use, using the 8 dimensions of data quality as a guide. We've also taken a look at how data flows through a hospital. In this module, we take a deeper look at some specific problems surrounding perinatal data and matrix. On average, the MARTA delivers about 10,500 babies per year, and that number is getting very close to 11,000. During each maternity journey, there are upwards of 180 individual data items collected, some multiple times. That's about 1.8 million data points collected each year. With that amount of data and the variety and complexity of some MARTA deliveries and outcomes, it's no wonder that the MARTA data is so highly sought after by Queensland Health. In fact, the MARTA data is the biggest of all Queensland hospitals, making up 1/6 of the total births, affecting state-based analysis, and Queensland has the highest quality data in Australia. Of all the data reporting that is sent from the MARTA to the various health agencies, the perinatal data collection is solely based upon the data collected by nursing and midwifery staff within the MARTA Mothers Public and Private Hospitals, South Brisbane and Redlands. Providing complete and accurate data is required as part of the licence to operate a maternity hospital. Perinatal data collection is used for epidemiology and statistical analysis and includes mother demographic data, various counts, measurements and results, indicators and clinical coding specific to maternity care cases. One of the most important sets of data relate to congenital anomalies. These appear on the discharge summary, providing the mother's GP with the best possible information to help care for mother and baby. The Queensland Perinatal Data Collection encompasses the period from conception through to mother separation from the birth hospital by discharge, transfer to another hospital or death. And for the baby, the period from birth to separation from the birth hospital by discharge, transfer, or death. But why do we collect and report the data? We know that the older woman, 38 years in age of older, have a higher incidence of stillbirth the longer the pregnancy goes beyond term, so the recommendation is that they are induced at around 38 weeks. How do we know these women are high risk? Because of all the data collected, clearly shows the correlation between maternal age, stillbirth, and length of pregnancy. Why do we want to know how many antenatal visits a woman has had during her pregnancy? Because there is an established relationship between the number of visits and perinatal outcomes. Include Indigenous status, and then you have another set of numbers showing that Indigenous women have even poorer outcomes the lower the amount of antenatal care. How do we know that there is increased risk of mental health issues during the perinatal period? Because of the research undertaken by the Queensland Mental Health Commission using perinatal data, and this has led to direct counselling, education and treatment plans for both mothers and healthcare practitioners. Completion of antenatals for unbooked patients, transfers from other facilities, premature deliveries or women who have had no antenatal care is often overlooked. A completed antenatal history and matrix is not only an important reference for all healthcare providers involved, but the data collected contributes to a large body of information used by state and federal agencies such as Queensland Health, the National Perinatal Data Collection, and the Australian Institute of Health and Welfare. All information is collected, collated and analysed for a reason. No data is collected simply for the sake of collecting. The antenatal booking in Matrix collects a large amount of epidemiologically significant information about demographics, obstetric and medical history, family and social history, lifestyle factors such as alcohol and illicit drug use, and smoking. Epidemiologists need robust information to support clinical practice and research. Did you know, of all of the mothers in Australia who gave birth in 2018, 21% were classified as obese and 26% were considered overweight. The stillbirth rate was 7%, down from 7.8% in 2009. 8% of mothers did not begin antenatal care until after 20 weeks gestation, and 74.2% of mothers received antenatal. Let's look at a scenario in Matrix. How to correctly record maternal diabetes and blood glucose monitoring in the baby. It's important to enter the correct type of diabetes in maternal complications. In this scenario, the mother developed gestational diabetes in her pregnancy, eventually requiring metformin and insulin for control. The baby is at risk of hypoglycemia and will require monitoring of blood glucose levels to ensure that hypoglycemia is identified and treated. In this case, blood glucose monitoring is normal. The correct way to record this is on the screen. A common mistake in recording normal blood glucose levels for the baby is to record hypoglycemia due to mother's gestational diabetes or pre-existing diabetes as the case may be, and then enter the blood glucose levels as normal. If the baby has hypoglycemia, the blood glucose monitoring must be hypoglycemia. It is also important that the type of diabetes diagnosed selected in maternal complications is consistent with the type of hypoglycemia diagnosed in the baby. If the mother has pre-existing diabetes and the baby has hypoglycemia as a result, the type of hypoglycemia selected for baby must be mother with pre-existing diabetes. The mother cannot have pre-existing diabetes and gestational diabetes, as these conditions are mutually exclusive. We've now come to the end of this course. In Module 4, we've taken a detailed look at perinatal data, what it is and why it's important, and we have looked at just one of the kinds of data quality problems that have to be resolved every month. I'd like to take this opportunity to personally thank Judy Clark who is the Perinatal Data Collection Officer for the MADA, for her valuable insight into the problems and challenges of perinatal data reporting. If you have questions around perinatal data itself, please reach out to Judy and she'd be happy to assist. If you find that Matrix isn't configured in a way that support your ways of working, then perhaps consider what kinds of changes could be made and log a support ticket. An important final point for this course is that I genuinely believe that no one comes to work deliberately wanting to make mistakes. We're all human and mistakes happen. We might be pushed for time or feel as though we're under-resourced and it's easy to make a mistake. But there are things we can do as individuals to help limit making mistakes and prevent mistakes from spreading. As you've seen in this course, data quality issues can have significant impacts in many ways, so the sooner we can get on top of data quality issues, the better off everyone will be, especially the patient.